Hey guys, welcome to today's webinar on high yield UKMLA topics, Rheumatology 1. My name is Dr. Phil. I'm here and I'm ready to go through with you in the next hour or so the most high yield rheumatology topics that could be asked for in the UKMLA exam and your medical finals. Without further ado, let's crack on with it. To give you a bit of a further idea of who I am, so my name is Dr. Phil. I'm the Global Medical Education Editor-in-Chief of Elsevier ClinicalKey Student, which is used throughout the UK, EU, Middle East, and the rest of the world, and it's been used by over 200,000 medical students worldwide. And you may have heard of Elsevier. So they are publishing books like Grey's Anatomy, Cromer and Clark as an example, and they're aimed at medical students to improve their medical knowledge. And they publish also exclusive journals like The Lancet, etc. Now, I myself have written and edited a series of 13 medical textbooks under the Crash Course book series, also published by Elsevier, which has sold over 1 million copies and been translated in over 8 different languages. And myself, I'm very much involved in a number of different exams, both at a national level and also international level as an examiner. And I'm really happy here today to be able to go through with you some of the most high yield topics that I can distill in the next hour. If you were to sit exam paper in medicine, I would expect around 8% of the paper to be focused on the rheumatology topics. And this is the list of the UKMLA conditions that can present itself. Now, bearing in mind that a lot of the topics, there may be some overlap with musculoskeletal and orthopedics, but there is also a definite medical aspect to it. And we will be focusing on the medical rheumatology aspect of this topic here today. The surgical aspect, the orthopedic section, will be covered in later webinars. But we are going to try and cover as much of the most high yield topics here today as possible for you. So we have the first question. Without further ado, let's crack on with it. We have got a 64-year-old man that presents to the GP with sudden onset pain and swelling at the base of his right thumb. And on examination, the first metacarpophalangeal joint was warm, swollen, erythematous. He's got a past medical history of chronic kidney disease, duodenal ulcers, and osteoarthritis in the knee. He drinks about 3 beers a day and has got a 20-pack year smoking history. When you examine the patient's afebrile and has got no other symptoms. The question is asking you, what's the most appropriate management for this patient? Do you go for ibuprofen? Do you use colchicine? Do you use prednisolone? Do you use indomethacin? Do you use paracetamol? Have a think, guys. Have a think. I'll give you about 30 seconds to have a think. So we've got a 64-year-old man that's come into the GP, sudden onset pain, right thumb. Okay, sudden onset pain, right thumb. Have a think. First metacarpophalangeal joint, warm, swollen, erythematous. Note his medical history of CKD, duodenal ulcers, and osteoarthritis in the knee. He is a drinker, 3 beers a day, and 20-pack year smoking history. Afebrile and got no other symptoms whatsoever. What's the most appropriate management? This is an applied type question in the sense that the examiners assume you know the diagnosis based on this, and then you can apply it so that you can give the right answer in terms of the management. Do you do A, ibuprofen, B, colchicine, C, prednisolone, D, indomethacin, or E, paracetamol? Let's go through the answer shortly. If you've chosen the answer colchicine, well done. You've got the answer spot on there. Now, firstly, let's just go through one thing at a time for this question, okay? And try and work out each of the options and why colchicine is correct answer. Number 1, the acute onset, pain, swelling at the first metacarpophalangeal joint of the right hand, of the right thumb, combined with the patient history of excessive alcohol consumption, and CKD points towards a diagnosis of gout. And gout, we're going to go through it in a deeper detail in a bit, is a crystal arthropathy, which is characterized, which presents with a unilateral acute inflammatory arthritis due to very high uric acid levels. Okay? The first-line treatment of gout is going to be NSAID. However, this patient has got CKD, and thus this is a contraindication. That's why colchicine is the agent of choice, okay? Because it will reduce inflammation, reduce swelling caused by the uric acid crystal deposition. Now, why not ibuprofen? A lot of you would have recognized that this might be gout, this might be something that needs anti-inflammatory. They may have chosen ibuprofen. Well, read the question. The question says CKD, and obviously an NSAID, which is normally a first-line treatment for gout due to its anti-inflammatory properties, will be contraindicated for these patients with duodenal ulcer, with CKD as well. Okay, so bear in mind, these are contraindications. Now, what about prednisolone? Well, some people do choose prednisolone, okay, and they do like to use it because sometimes steroids are used to treat acute gout attack, and they are considered after NSAID or after colchicine if ibuprofen and colchicine are contraindicated too, okay, and only if they're contraindicated. Whereas in this case, there is no such contraindication. Now, what about indomethacin? And again, indomethacin is also an NSAID. And obviously, again, there are contraindications, gastric ulcers, etc., including CKD. So bear that in mind. Paracetamol. So why not paracetamol? So this patient's got a CKD. You're not going to give an NSAID. What about paracetamol? I hear you ask. Well, paracetamol is a very effective analgesic for pain relief, but it lacks the anti-inflammatory properties. So it's not going to suppress the inflammation caused by uric acid crystals in gout. So the answer is B, colchicine. Gout is probably one of the most common tested topics in rheumatology that you're going to get, okay? I wouldn't go through some of the nice guidelines that relates to acute gout, which is one of the most common inflammatory arthritis. Now, gout is going to be diagnosed clinically. It's based on the following presentation. So the rapid onset, severe pain. Often, when I say rapid, it means overnight. That's the speed at which it comes on. There was no pain before, and there is sudden pain, so much so that you might not be able to wait there. There is redness, there's swelling, and is commonly in the first metatarsopharyngeal joint or presents as tophi. It could be in other joints as well, okay? Don't get me wrong. It's not just in the thumb base. It's not just in the big toe, which is the first metatarsopharyngeal joint. It's also in other joints as well. So the ankle, the knee, the hand, the wrist, the elbow, the midfoot, what we call the bootlace area, the area where you tie your shoelace, the midfoot area also can be affected. Now, when people say rapid onset, severe pain, often people think, oh, what about septic arthritis? Could it be septic arthritis? Well, obviously, in the case that we saw in the last one, that chap had no fever. So he was afebrile, no other symptoms. Whereas with septic arthritis, we'd expect to have an element of systemic response, including fevers. Obviously, if there is a diagnosis is uncertain, then you need to refer to secondary care for joint aspiration plus minus imaging and same-day blood tests as well. Now, I hear you ask, what about serum urate? Is that helpful at all? Well, SUA, serum uric acid levels, can be helpful. So during the clinical presentation, if it is acute gout and you think it's acute gout, and you measure the serum uric acid level as over 360, then the diagnosis is confirmed. Okay. However, if you do it during the acute flare, but it's actually less than 360, it doesn't mean anything. It doesn't exclude it because during attacks, the level could be normal, could be high, or could be low. You have to repeat it 2 weeks after the flare. The diagnosis of acute gout normally is a clinical diagnosis. Bear that in mind. Now, why is that important? Because I'll show that later when we come to long-term management. Now, the acute management of gout, as I elicited before, is going to be NSAIDs, colchicine, or a very short course of prednisolone. It's all based on the patient's comorbidities and what they can tolerate. Now, obviously, if someone's got NSAID, someone's got oral corticosteroid, you may want to consider giving a PPI, okay? And if you do give colchicine, remember that sometimes it is gastrotoxic. It can cause diarrhea as the most common side effect in terms of toxicity, okay? Now, obviously, if they don't tolerate NSAID, don't tolerate colchicine, think about giving corticosteroid, either IM or as an injection or as an oral prednisolone. Just bear that in mind. Obviously, patients can use other methods to reduce pain, ice packs, etc., and not non-weight bearing, things like that. Now, what about in terms of longer term management? How are you going to manage someone who's got gout or someone who's got acute flare-ups of gout? That's a good question. The longer term management of gout basically is to offer something called urate lowering therapy, ULTs, and these can encompass things like allopurinol or febuxostat. And often you offer these to patients who, if they have a preference, for example, if they've got multiple flare-ups, if they're in CKD, stages 3 and above, if they're on directed therapy, or they've got tophi already. These are patients who are at high risk of having this again. We need to decrease the uric acid. And we normally start it around 2 weeks after the flare has settled down. Otherwise, if you start it too early, it's going to cause another flare-up and potentially elongate the current symptom of acute gout attack. Now, if you were going to start if you were going to start a uric acid lowering therapy, you were aiming for a target of less than 360, and you would monitor it on a monthly basis. However, if this is an acute gout attack that comes again and again and again, ongoing flare-ups, or they have tophi, then you'd consider aiming for a more stringent level, a stringent threshold of less than 300. Okay, so bear that in mind. Now, obviously, if it's stable, you consider annual monitoring of serum uric acid levels too. So that's the short-term management, and more importantly, the long-term management, which is an examiner favorite. I just wanted to show you some photo of advanced gout. So you can see tophish gout. This is gout with lots of tophi, with multiple intra-articular and peri-articular, so in the joint and around the joint tophi. And you can see that in picture A, where we have on the big toe, on the first metatarsophalangeal joint, as well as that on B, which is also on the hands with severe tophus gout. You can see the swelling, you can see the redness, and you can imagine this is severe pain. This is very much advanced disease. Without further ado, let's crack on with question number 2. So we've got a 54-year-old man that comes to A&E with a 24-hour history of a swollen, painful joint, of a knee specifically, with a fever now, okay? Different to the first one that we have. Examination shows erythema, warm, synovial effusion of the knee joint is limited, passive range of motion, and tenderness on palpation. No other joint inflammation are there. Okay, you take a sample of fluid and you do light microscopy from the aspirated synovial fluid, and this is what you see. The question is not what is the diagnosis. The question is, what is the following metabolic disorders that directly predisposes to the most likely diagnosis? So the question is, which of the following metabolic disorders directly predisposed increase the risks of the most likely diagnosis? Have a think. Okay, have a think of what this could be. So we've got the patient with a single painful knee, he's got a fever, 24-hour history, very acute, warm synovial effusion. You tap the fluid, you look at under the microscope, and this is what you see. Which of the following disorders, A, B, C, D, or E, is predisposed to the most likely diagnosis? The question is, what's the most likely diagnosis? I'll give you a couple more seconds, have a think about it, and we'll go through the next slide. The way I see the differential diagnosis of a patient in any exam question with acute monoarticular arthritis is very important to consider the potential diagnosis. Now, the most differential diagnosis that you can have for a painful knee, or any monoarticular inflammatory condition, arthritis, would be number 1, septic arthritis. Could it be caused by a bacteria or fungal pathogen? Because Staph aureus is the most frequent culprit, because obviously septic arthritis is a medical emergency that requires prompt diagnosis and treatment. Otherwise, it doesn't cause joint destruction and systemic complications like sepsis. Or B2, another differential diagnosis is crystal arthropathy. We discussed about gout in the last question. There's also pseudogout, which is calcium pyrophosphate dihydrate crystals. That both can cause acute monoarticular arthritis, and both are associated with pain, swelling, erythema of the joint. Could it be number 3, reactive arthritis? So this is more of a sterile inflammatory response to a more distant infection, so in the GI or GU tract. So such organisms include things like chlamydia, salmonella, shigella, campylobacter. Or it could be traumatic arthritis. You've had a direct injury to the joint that's led to acute inflammation, pain, and swelling. And osteoarthritis, of course, don't forget, which is one of the most common causes, which is a chronic condition. So that's not acute, really. It's chronic. It's been there for months and years, getting worse and worse, and presents with acute exacerbation. Maybe gets worse due to overuse, gym, trauma, that sort of stuff. But it more appears in weight-bearing joints, like the knee. Now, what is this? So we have all sorts of differentials here. The diagnosis that we can get is the microscopy, this compensated polarized microscopy. And what does it show? Well, what it shows, actually, it shows positively bifringent rhomboid-shaped crystals that you can see. The crystals, clearly crystalline structure, and they look rhomboid shape, okay? And this microscopy is so important because this tells you the difference between gout and pseudogout, because you see these crystals and you realize already that this is going to be crystal arthropathy. So there's going to be either gout or pseudogout. So the question is, what makes you think one or the other? Well, if number 1 is bifringence, okay? Pseudogout, CPPD crystals, they are weakly positive bifringent. So that means they appear blue. Whereas uric acid crystals, urate crystals, they're negatively bifringent. So that means they look yellow. What about the different sizes? Okay, so CPPD crystal, this is pseudogout, they're rhomboid, okay? So the rod-shaped, very blunt ends, and they're very relatively uniform shape, whereas uric acid crystals, they're very needle-like, slender rods. And I remember this because the way I remember it is the fact that gout is like walking on needles. So that's what triggers me to remember that the gout microscopy images are shaped like needles. Now, what about the actual condition then? So we know that based on the rhomboid shape in the microscopy, based on the differential diagnosis in the clinical vignette, is likely to be pseudogout, which is calcium pyrophosphate dihydrate crystal deposition, okay? Because of the monoarticular pain, that's acute, that's swelling. What about in terms of the options here? Okay, so option A is hyperphosphatasia. Now, hyperphosphatasia means that there's an increase in alkaline phosphatase levels. That does not directly predispose to pseudogout because it is low hypophosphatasia. It's a very rare inherited disorder that's characterized by low ALP levels that leads to pseudogout, because ALP, alkaline phosphatase, is responsible for hydrolyzing inorganic pyrophosphate. So its deficiency, ALP's deficiency, the enzyme's deficiency, results in excessive accumulation of calcium pyrophosphate crystals in the joint. What about B, hyperthyroidism? Well, hyperthyroidism can lead to various metabolic musculoskeletal manifestations. We know that could be things like osteoporosis, hypercalcemia, but it does not directly predispose to pseudogout itself. The presence of the rhomboid-shaped crystals in the synovial fluid is specific for CPPD crystal deposition, not hyperthyroid. What about hyperuricemia? So hyperuricemia is a key feature of gout. So that's another crystal arthropathy. And in gout, monosodium urate crystals, they deposit in the joints, causing acute severe joint pain and swelling. But we see here the crystals in the microscopy, they're negatively bifringent, and also they are rhomboid shaped. So that's why it's different. What about hypomagnesia? Well, spot on. If you chose the hypomagnesia, well done. That's the right answer. Hypomagnesia, low magnesium level, has been recognized as a predisposing factor for pseudogout. Okay, because magnesium is a cofactor for ALP, the enzyme that hydrolyzes inorganic pyrophosphate. Now, in magnesium deficiency, ALP activity is reduced, so that leads to an excessive accumulation of inorganic pyrophosphate and thus the formation of CPPD crystals. So what about hypoparathyroidism? Well, actually, you would not be too far off the mark. It is actually hyperparathyroidism, not hypoparathyroidism, that's associated with the increased risk of pseudogout, because hyperparathyroidism leads to elevated serum calcium levels, which can obviously contribute to the CPPD crystal formation. Now, conversely, hypoparathyroidism that results in hypocalcemia and hyperphosphatemia, which is not directly linked to pseudogout. So the key point to take home from this message is the fact that pseudogout is caused by CPPD crystals in the joint. It very much mimics gout, apart from the fact that there are other metabolic causes of this, and the fact that in the microscopy it looks different. Okay, think rhomboid shape, think negative bifringent. Good, excellent. Let's crack on with the next question. So we have got a 68-year-old woman that's been referred to outpatient after a fracture of the distal radius. He's got 4-month history of lower back pain. That's worse when they're lifting objects. Past medical history, got a 20-year history of adrenal insufficiency. He's got vitiligo. That's being controlled by hydrocortisone, and has got esophagitis as well. So we've got vertebral tenderness of the spine. And also DEXA shows a T-score of -2.6. So what do you do for this patient? With who has got a DEXA scan, a T-score of -2.6, very important, and also has got a lot of comorbidities, including adrenal insufficiency and vitiligo. That's being used with hydrocortisone, and also esophagitis as well. What do you do for this woman who's suffered a fracture? Give you 5 seconds. Pause the video if you need more time. Pause it if you need more time. Have a think. Okay? Now, the correct answer in this case, obviously, a patient with a history of fracture, persistent lower back pain, and also a DEXA scan that's -2.6, a T-score. That's a diagnosis of osteoporosis. So if you think this is osteoporosis, well done, you got the answer correct. Now, the question is, where do we go in terms of further management? Where do we go next? Because that's all going to be based on the clinical vignette in terms of the contraindication. So the vast majority of students here will jump into alendronic acid, alendronate in option A. That is incorrect, because alendronic acid, alendronate, is an oral bisphosphonate. It's a first-line treatment for osteoporosis, normally, right? Because of its ability to inhibit osteoclastic activity and bone resorption. However, in this particular patient, alendronic acid is contraindicated because we've got a history of esophagitis already. And we know that bisphosphonate can exacerbate existing esophageal disorders and must be avoided in this case. So even though you've got the diagnosis of osteoporosis, the management is not going to be the first-line management using alendronic acid for this particular individual because of the comorbidities. Bear that in mind. Some students actually like to choose calcium and vitamin D supplementation, and I would agree with you in normal circumstances, because even though calcium and vitamin D supplementation is essential for all patients with osteoporosis to reduce the fracture risk, it's not considered a definitive treatment, okay? Because these supplements should always be used in conjunction with other interventions, much more definitive interventions, for the optimal management of osteoporosis, okay? If you did choose C, denosumab, well done. Okay, well done. Let me expand that a little bit more. Denosumab is a monoclonal antibody that inhibits the rank RNK ligand and is the most appropriate choice for this patient. Okay, why is it? Well, it's really a second-line treatment for osteoporosis if bisphosphonates are contraindicated or aren't tolerated. And denosumab really reduces the fracture rate and is safe for patients with esophagitis. So that's the best option for this case. Now, you might ask me, Phil, why don't you just give out PPIs, proton pump inhibitors, like omeprazole, for patients with this esophagitis and taking an alendronic acid? Well, that's a good question. What I would say is the fact that the PPIs are not going to be useful due to the local effects of alendronic acid, alendronate, on the esophagus, whereas the PPIs will normally work on the stomach, the gastric side. So that's why. What about raloxifene? D. That's incorrect, because raloxifene is a serum estrogen receptor modulator, SERM, and that's normally indicated for the management of osteoporosis in postmenopausal women. So it works by binding to the estrogen receptors, inhibits osteoclastic action. However, the raloxifene is typically only reserved when bisphosphonate and denosumab are not tolerated at all, which is not this particular case. Strontium. You may have strontium being used very many years in the past, okay, because it does a couple of things. Number one, it increases osteoblast activity and also reduces bone resorption by inhibiting osteoclast as well. Now, because It has side effects, terrible ones actually. It causes cardiovascular and thromboembolic events. So it should be contraindicated for a lot of patients. It's only considered really as a last resort when other therapies aren't indicated. So in which case, denosumab is safer and much more appropriate. Okay, good. Let's go through a bit more of a deeper dive into osteoporosis. One of the main things I want you to remember, out of this talk today, is that osteoporosis is defined as a bone mineral density T-score less than 2.5 based on the DEXA scanning, okay? And the preferred site, the area that people want for it to be diagnosed, is going to be the femoral neck. Okay. Now, you may see in trickier exam questions whereby they're saying, oh, the bone mineral density T-score in the femoral neck, in the spine, they may even use it in the arm. They may give you a range of T-scores. Now, the question is, which one do you take as the first line? Well, the preferred site really for the diagnosis of osteoporosis using DEXA scan is the femoral neck. Femoral neck. Remember that. Okay. Now, sometimes people use spine. Now, I would say the fact that DEXA scanning in the spine is sometimes not suitable because obviously there is a higher prevalence of degenerative change, so wear and tear, which can cause an artificial increase in bone mineral density, so it's not going to give an accurate reading. However, it can be used as an alternative, for example, if the patient's got bilateral hip replacement and has got metalwork everywhere, okay? And obviously you might ask, well, what happens if you've got spinal operation and you've got both hip and both spine being operated upon and got metalwork? Then where do you go next? Well, if the spine can't be used, if the hip can't be used, if the femur can't be used, then you might want to do it at the distal radius. That's the third line. So bear that in mind. Now, how do you manage osteoporosis? First line, simple, conservative lifestyle. Stop smoking, reduce alcohol intake, less than 2 units a day. Okay, that's quite important. Also, make sure your calcium intake is good, over 700 milligrams a day, ideally through dietary intake rather than supplements. But if you can't, then go through supplements. And also 800 international units of vitamin D as well. It's very important, guys, to get lots of exercise. Weight-bearing exercise is so important. So you've heard these stories, you may have read about it, even of astronauts going in space and coming back home with osteopenia on land because there's no gravity, so there's no force of impact. So that's why it's very important for elderly patients to have sometimes not just isometric exercise where they're pushing against, using body weight, but actually a lot of good weight-bearing exercise where they are being eccentrically pushed. They're doing excess weight as well. And obviously we want to prevent a fall, okay? So obviously it's best to prevent a fall and prevent a fracture rather than to rescue a fracture. So if someone's a falls risk, you better refer them to a falls program as well to prevent any fragility fractures. Now, in terms of medication, in terms of management, it's really divided into 2 different categories. One is anti-resorptive and the other one is anabolic. Anabolic means the build-up, which is obviously the opposite of catabolic. You may have heard it before, okay? So the anti-resorptive treatments are the ones that you're going to be more familiar with. So things like bisphosphonates like alendronic acid, rosindronate, zolindronate, etc. That's the ones listed here. And they work by slowing down bone turnover because they inhibit osteoclast. Okay. However, there are now a new focus on the newer drugs, the newer anabolic drugs, especially in the exams, such as teriparatide and rosuzumab. Now, the first line treatment is going to be things like bisphosphonates, alendronic acid, rosindronate in the majority of cases. However, there are certain cases where you're not going to be a first line. Let me give an example. If there are side effects in terms of esophagitis, gastric ulcers, that sort of stuff, maybe you can give it intravenous, IV zolindronic acid. Very much first line, if that's the case. It's cost effective. Now, obviously, in the last case that we saw, in the last clinical vignette, the zolindronic acid wasn't offered. But if it was offered, maybe that would have been an ideal solution for this particular gentleman who needed it, if he couldn't tolerate oral bisphosphonate. Denosumab, we've discussed this before. Raloxifene, it can be used, and sometimes people use HRT, which is generally for younger women, so under the age of 60 with menopausal symptoms as well. Now, anabolic drugs, so the ones that we've listed here, teriparatide and rosuzumab, these are first-line therapy for those in a very high-risk group, okay? very high risk group of falls. So just not falls, of osteoporosis. Bear that in mind. So what about this particular patient then? We've got a 58-year-old man, 4-month history of weight loss, drenching night sweat, myalgia, severe occipital headache. And when you examine the patient, there's skull pain, there's left-sided temporal tenderness, there's strong peripheral pulses, the blood pressure is hypertensive, is slightly anemic, CK, creatine kinase, is slightly high, ESR is high, plus. So what is going to be the diagnosis? And more importantly, the question is asking you what's the most appropriate investigation for this particular individual. So what do you think is the answer? Have a think. Okay, is it A, anchor, B, echocardiogram, C, the CT, D, CT, PET CT, or E, muscle biopsy? What do you do? Which is the proper investigation for this gentleman who's got systemic symptoms, which includes weight loss, night sweat, myalgia, headaches, and also scalp pain, temporal tenderness, etc., with deranged blood test results? Which one would you go for? Give you a couple more seconds to have a think about before we reveal the answer. The answer is D, CT PET scan. So why? So let's have a think. Okay, let's have a think what this condition has. So this patient's symptom has weight loss, night sweat, constitutional symptoms basically, myalgia. They also got severe occipital headaches, and that suggests to me that this is suggestive overall of a systemic inflammatory process. Okay, now the examiner give you some further information here. And remember what the examiner does. The examiner never tries to trick you, really. There's never going to give you some red herring in the majority of cases. So the information that they give you is going to be important. In this particular case, we've got scalp hyperesthesia and temporal tenderness, okay? And that further points towards a diagnosis of giant cell arteritis, okay? That's also known as temporal arteritis too. So that's GCA. That points towards GCA, given the scalp tenderness, given the temporal tenderness as well. It's the age group. It fits. It's very common in the over 50s. This particular chap is at 58 as well. And GCA also causes elevated inflammatory ESR and CRP results as well too. And obviously, we may want to go for a temporal artery biopsy or ultrasound depending on the guidelines that you want to follow. Okay. And obviously with GCA, you need to go through. Now, what about this then? Okay, so if you're going to go for, if we think this is GCA, so why do we choose D? Okay, let's go through each one in turn. Why isn't it anchor? Well, anchor, if you were thinking about things like small vessel vasculitides, so granulomatoses with polyangiitis, GPA, or microscopic polyangiitis, MPA, but with this patient's presentation, with this scalp pain and temporal tenderness, that tells me is GCA, giant cell arteritis. This is a large vessel vasculitides. So anchor would not be appropriate at this stage. Anchor is used for small vessel vasculitic disorders. What about echocardiogram? If you thought that this could be due to something like infective endocarditis, causing anemia, drenching night sweat, weight loss, constitutional symptoms, you might be right. Okay, you might be right. But because of the systemic inflammatory response, however, it wouldn't explain anything else in this particular case. It wouldn't explain the findings in the scalp, for example. What about CT PET scan? What about a CT chest after pelvis? Now that's relatively common. If you thought this was something like a solid tumor, if this was like a tumor or this was something like a lymphoma, you were that this got metastasis somewhere, that could be a relatively reasonable suggestion to take if you're thinking about constitutional B symptoms that this patient has. But for someone like this, it wouldn't explain the scalp tenderness. And it really wouldn't explain neatly about the rest of the symptoms that this patient presents with. Okay, so while CT chest after pelvis may be a good useful step if this is very more generic, the fact that we've got scalp tenderness, temporal tenderness as well, that points toward GCA, in which case would you not do a CT chest after pelvis, because it wouldn't tell us about the vessels and what's been happening there. The difference is CT PET scan. Because a CT PET scan is useful, because it will tell us about large vessel inflammation. Okay, it'll tell me about large vessel inflammation in the arteries, such as the aorta and the branches of the aorta, and also it can help establish the extent of the disease and guide how we're going to treat it. Okay, now the second thing apart from that is the temporal artery biopsy or ultrasound can also be considered as a firm diagnosis of this. Now, some of you will say, oh, CK is high, quick, let's jump to that. Now, that's useful if there's something like a myopathy to investigate the cause of a myalgia, obviously. But however, this is more to do with large artery issues rather than a primary muscle disorder. Okay, so that's not going to be the particular case, and it's not going to be as useful for us here. Whereas GCA is what this points to. Now, the diagnosis of GCA, giant cell arteritis, is almost always clinical. Okay, 75% of patients will have a headache. Normally, a very dull headache in the temporal region, but it can be occipital, can be parietal, and it carries on insidiously. It means it just carries on gradually. It's not like a thunderclap headache. It progresses through time. Sometimes people get visual symptoms as well. Okay, the reason why it's so important, the reason why you need to examine the eyes, for example, is the fact that obviously if it affects the central retinal arteries, then it can cause partial or complete loss of vision, or even diplopia for some cases. Now, obviously, scalp tenderness is useful to note, and jaw or tongue claudication is important, and that happens around a third of the cases, because when the tongue is chewing, and you get this claudication symptom, this pain in the jaw, pain in the tongue, that's due to ischemia in the masseter muscles. So almost always you're going to get systemic symptoms, really. And sometimes that can involve things like PMR symptoms as well, polymyalgia rheumatica, which may coexist. By that I mean you got proximal muscle pains, early morning stiffness, so such as the myalgia that we see in this last vignette that we had here. Okay. Now, what you're going to do, you're obviously going to palpate for the temporal arteries on the side of the head. You're going to palpate for hard lumps and the lack of pulsation. They're like knots, basically. And you may want to do a full vascular examination to look for carotid bruit, differential blood pressure in both arms, because that might just tell you of the infiltration of the large vessel vasculitides as well. And take a look at the eyes as well. Acuity, fundoscopy, look for any signs of visual disturbance too. And whilst you're doing that, make sure that you take some ESR and CRP, because the vast majority of patients with GCA will have elevated inflammatory markers, even though they're not very specific. And if you do suspect GCA, please start prednisolone, start steroid early, even when you refer the patient on the same day. The reason being, and you shouldn't be waiting for outpatient review before starting a prednisolone steroid, the reason being is that it can cause catastrophic disability in the form of blindness. So that's why you should start it. And you should consider things like PPI, omeprazole, cover, etc. Now, sometimes in the old school days, you might have started or read about in textbooks that you might start aspirin alongside this, but it's not the case today. So you do not start aspirin. You just start prednisolone and you start a PPI cover if it's relevant. And obviously onward referral for rheumatology for them to monitor and the disease progression. And I just wanted to show you here in this particular photo, this is a gentleman on the left-hand side where we can see a knotty appearance, almost like ropes. And there's knots on the ropes as well of a temporal artery, which isn't very pulsatile at all, but is tender when you touch it. This is the keeping with GCA, giant cell arteritis, or temporal arteritis, based on the anatomical location. So, next question now. We've got a 75-year-old woman that's come in with a 3-week history of pain and stiffness in the pelvis. That's worse on walking. And when you examine, the hip movement is painful bilaterally. Pain limits the range of motion. Power is intact. Blood results show increased ESR, increased CRP. It's a normal CK. You started prednisolone already. Then the question is, which of the following do you offer prior to starting prednisolone? Before you start a steroid, what else do you give? So the question, have a think. Do you give A, bisphosphonate, calcium, vitamin D? Do you B, just give calcium, vitamin D? Do you C, just give bisphosphonate, or D, methotrexate? Or E, you don't need anything on top of what's been given apart from prednisolone? Have a think of what this patient you need to give, okay? Now, if you chose A, that's the correct answer. But let's focus on Vinia. What do you think the patient actually has? So I'm thinking that the patient has PMR because of the following reasons. So this patient's got polymyalgia rheumatica because it normally affects elderly patients. So this patient's 75, which falls in the norm of the age range. And number 2, PMR presents with bilateral pain, stiffness in the pelvic girdle. That's worse in the morning. So that's classic. and the pain often presents in the shoulders, pelvic area, morning stiffness lasting more than 45 minutes, and it can develop over a period of days and weeks. So certainly this particular patient, this patient has had a 3-week history, so very much in keeping there. It causes an increased elevated inflammatory markers, ESR, CRP, etc. as well. Okay, the CK is normal, which is reassuring. It's not going to be some sort of myopathy, and obviously there's no other joint involvement, especially small joints of the hand or feet, which will exclude something like rheumatoid arthritis. Okay, now why would you choose A, bisphosphonate, calcium, and vitamin D? You've thrown the kitchen sink for this patient. Well, it's very simple. If someone's age 65 and over and they've started long-term steroids, so by long-term I mean the definition is more than 3 months and over, they're at very high risk for osteoporotic fractures. So in this case, this patient meets the criteria of PMR, is over the age of 65, is going to be on steroids probably for a good year or so in terms of reduced regimen. It's going to be a long time, steroid dose. So that's why bisphosphonate, calcium, and vitamin D should be offered to reduce the risk of corticosteroid-induced osteoporosis and then subsequent fracture. Now, you might say, Dr. Phil, why don't we just give calcium and vitamin D? That's a good question. Well, I told you before, calcium and vitamin D supplementation is important for people on any risk of osteoporosis and for the elderly in itself. However, you need to give bisphosphonates as well for those who are at high risk of osteoporotic fractures, such as this particular individual who's on long-term or will be on long-term corticosteroids. What about just bisphosphonates without the calcium and the vitamin D? Now, calcium bisphosphonate really should be given alone without calcium and vitamin D, okay? And they should always be given with it. Otherwise, it will prevent things like hypocalcemia, low calcium level, because of the drugs, the bisphosphonate's mechanism of action, which is to aim to reduce calcium efflux from the bone into the circulation. So some of you may just choose methotrexate, thinking that this is some sort of a DMARD that can be used in for things like PMR. However, that methotrexate really is only reserved for people who are non-responsive for corticosteroid or really have got a huge amount of corticosteroid side effects. I mean things like psychosis, etc., that sort of stuff. And then it's really not considered first line. So obviously, if you thought no additional treatment is required, that's incorrect. Given the age concern and given the fact that the patient has got a diagnosis of PMR, you should be treating them. Now, I mentioned a bit about the PMR here on the slide before, as well as I'm going to mention a bit more now. It's quite associated with giant cell arteriitis we discussed before, and approximately maybe 20%, 1 in 5 of patients with PMR go on to develop giant cell arteriitis as well. So it's a good risk factor. Okay. Now, obviously, you give a dose of prednisolone, 15 milligrams a day, and it tapers. We're talking months. Okay. And most patients may require treatment for years, 1 to 2 years, the norm. Giving the steroid treatment straight away, okay, it should give you an immediate response and improvement, normally within 24 to 72 hours. Okay, so if the symptom goes away, better than 70% improvement, it's almost diagnostic of PMR, including all the clinical signs you have elicited. Now, having said that, even after you wean off steroid completely, more than 1 in 2, 50% of patients with PMR will relapse at some point. So bear that in mind. Now, the learning point from this particular question is that patients who are on prednisolone, which is greater than or equal to 7.5 milligram of prednisolone from greater than or for 3 months, are very high risk of fractures, and they should be started on bisphosphonate, calcium, vitamin D, even before developing osteopenia, before developing osteoporosis. They should be started on bone protection straight away without any delay. Good, guys. We're on question 6 now. So this is a 35-year-old man that's got a 48-hour history of pain, stiffness in the small joints of his hand and feet. He's got previous episodes over the last year. He's saying that the stiffness is worse in the early morning and after periods of inactivity, and is gradually relieved by gentle exercise. His last medical history was notable for hyperthyroidism, and we've got increased ESR, CRP level, and positive rheumatoid factor. So which is the following extra articulate manifestation of this condition? amyloidosis, pulmonary fibrosis, subcut nodules, episcleritis, vasculitis. Have a think, guys. Which one is the most common extra-articular, so outside the joint manifestation for this particular diagnosis? And the question is, what is the diagnosis? Give you 5 more seconds to have a think. Now, if you have chosen option C, subcut nodules, well done. Give a clap for yourself. Now, this is a 35-year-old man. He's got the following key features that jumps out at me. Symmetrical pain, stiffness in the small joints of the hand and feet, morning stiffness that improves with exercise, recurrent episode over the last year, elevated systemic inflammation markers, ESR, CRP, and positive rheumatoid factor. Now, this points to me that this is probably rheumatoid arthritis, which is going to be a chronic systemic autoimmune disorder that's normally characterized by a symmetrical polyarthropathy. So it affects the small joints and also the medium joints in the hand and feet. Okay, so the pain and the stiffness in the joints is classical presentation here. And morning stiffness is going to be very important here, which improves with activity. Remember, this is different to osteoarthritis, wear and tear, where you're going to get worsening pain towards the end of the day. With osteoarthritis, wear and tear, the more you use it, the worse the pain it gets. Whereas this exercise is helpful. Okay, so what about in terms of the actual answer options that you have here? Amyloidosis. Now, amyloidosis is a very rare, severe complication of very poorly controlled rheumatoid arthritis. And it occurs due to amyloid deposition in the various organs, but this is not the most common extra-articular manifestation of rheumatoid arthritis, and neither is pulmonary fibrosis, okay? Because that's much more common with interstitial lung diseases. Subcutaneous nodule is the correct answer because that occurs in about quarter to about a third of all rheumatoid arthritis patients if they're not managed properly. So often these are the elderly patients who don't have the access to the acute and early referral that we have now. And these nodules are firm, they're non-tender, they're mobile, and they can be found on the extensor surface of the forearms, the elbows, the fingers, and also on the Achilles tendon and the sacrum. Okay, and these are often in patients who have severe active disease or seropositive, so they got positive rheumatoid factor, they got positive anti-CCP antibodies as well. Obviously, these can cause mechanical discomfort because due to pressure or due to friction, but they themselves are asymptomatic. Now, you do get some element of ocular manifestation of rheumatoid arthritis. By that, I mean things like episcleritis and scleritis, okay? But they're much, much less common than subcutaneous nodule. And episcleritis, to give you a bit of a reminder, is just a benign self-limiting condition that's characterized by episodic inflammation of the episcleral tissue, okay? And obviously scleritis, though, is another very rare complication, is much more severe because it can lead to visual loss if it's not promptly treated. What about vasculitis? Well, rheumatoid vasculitis is a very rare complication of medium-sized blood vessels, but much, much less common than subcutaneous nodules in terms of the manifestation of that particular condition. So bear that in mind. One of the main key clinical features for someone with rheumatoid arthritis, bear in mind, is things like synovitis, okay? So by that, I mean you've got pain, swelling in the joint itself, and the pain is going to be worse at rest, and is going to be, or during periods when you're not actually moving at all. And the swelling is not, is around the joint, but not of the bone itself. That's why you get this boggy feeling. This is all tissue there as well. Okay, so any joint can be affected, but most commonly is symmetrical. Look at the pictures, it's symmetrical of a small joint, small hands, small feet, okay? And you get stiffness in the morning. And you would want to do blood tests. We discussed about the inflammatory markers and the more specific markers. Anti-CCP is a better, more specific that rheumatoid factor. And you need to refer. The reason why you need to refer is the fact that you want to have not longer than 3 months before the onset of symptoms and the start of treatment, okay? Because you want to start treatment like DMARDs, which is disease-modifying drugs, as early as possible because it reduces disease remission and improves functional outcomes and prevents disability. So just look at the pictures on the right-hand side, right? These are patients with severe rheumatoid arthritis. You can see in picture A, there's lots of polyarticular, so lots of multiple joints, polyarticular swelling of the proximal interphalangeal joints with a wrist deformity as well. And B, you can see the subluxation of the wrist, and you can see the ulnar deviation, okay, at the metacarpal phalangeal joint. So the hands are pointed towards the ulnar, and you can also see the boutonniere deformity of the thumb. Look at that shape; it looks like a banana, so it's deformed like a banana. That's boutonniere deformity. And take a look at the first finger there. It looks like a swan neck, doesn't it? At the proximal interphalangeal joints there, PIPs. So where it looks really at the distal interphalangeal joints rather. There's a fixed deformity there, and you can see again in picture C the ulnar deformity there and massive MCP swelling there. Now, we've got a 35-year-old man that presents to the GP. He's got a 2-month history of pain, stiffness on the right knee. He's got a sticky discharge from the eyes. The patient complains of a burning sensation when he passes urine and a discharge from the penis. He regularly has unprotected sexual intercourse, and the effects joints are tender and swollen. Which of the following is a poor prognostic factor under the various conditions? Which is the worst prognostic factor in this? The question is, do you know the condition firstly? Do you know the condition? If you know the condition, then do you know the risk factor and the prognostic factor for this particular condition? I'll give you another couple more seconds to guess. If you've guessed answer A, which is age of disease onset less than 16, you'd be correct. Let's go through this now. So firstly, the key question is, what is the diagnosis? The answer is, if you know already, well done. It is reactive arthritis. This is Rhesus syndrome, okay? This is consistent with reactive arthritis, Rhesus syndrome. This is a triad of asymmetrical oligoarthritis, mainly involving the lower extremities. You've got conjunctivitis, you've got urethritis as well. So can't see, can't pee, can't climb a tree is what they normally say in terms of a triad, okay? So this is the 3 components there. And also we've got risk factors: engaging in unprotected sexual intercourse. This is a risk factor for developing and getting chlamydia infection, which is a common trigger for reactive arthritis. So why is A the most important prognostic factor then out of the ones listed? Because obviously reactive arthritis is more common in ages of 20 to 40, but if someone's young, below the age of 16, then it's much more severe course, worse prognosis, okay? Juvenile onset reactive arthritis, much more aggressive, high likelihood of chronic symptoms, and also the other issues. And these are patients who need early initiation of DMARD drugs or biological agents as well. So what about ankle involvement? So obviously reactive arthritis can affect an ankle joint, is much more common in the lower limbs. It doesn't necessarily mean it's a poor prognosis. However, if the reactive arthritis involves the sacroiliac joints, the lumbar spine, that's going to more likely indicate something worse in terms of treatment-resistant chronic course of disease. Female sex is incorrect because it's in and of by itself not considered a poor prognostic factor. However, females can develop ongoing chronic symptoms more. Rheumatoid positivity is incorrect as well, because that's normally associated with rheumatoid arthritis. And unresponsive to paracetamol is incorrect too. Paracetamol is just a mild analgesic, and obviously anti-inflammatory drugs are the first-line treatment for reactive arthritis. So this is a diagnostic question now. Let's see whether you know the answer. A, B, C, D, or E. We've got a 74-year-old man that's got a number of frequent falls. He's got difficulty carrying food bags, and he slings them over his elbows. He's got difficulty opening jars of food as well. He's got problems with swallow. He's got regurgitation as well. He's got weakness in the flexor muscles of his forearm and quadriceps. No evidence of fasciculations, and reflexes are normal bilateral. What's the most likely diagnosis? Polymyositis, inclusion body myositis, MND, myasthenia gravis, or hypothyroidism. We're going to give you 3 more seconds. Have a think, have a consider about this 74-year-old man that's got lots of falls. He's got issues with weakness, swallowing problems, regurgitation, and he's got main issues are the flexors as well. No fasciculations and normal reflexes. Have a think. this particular patient, in terms of diagnosis, is IBM, which is inclusion body myositis, is the most consistent with that. So it's rare, it's an important subtype of idiopathic inflammatory myopathy. The main reason why it tells me is the fact that this affects older individuals, so over the age of 50, and also with the patterns of weakness, because IBM involves the distal muscles of the upper limbs, so the finger, the wrist flexors, and the proximal muscles of the lower limbs, so the quadriceps as well, which is exactly what we're seeing here in the vignette. Also, IBM results in dysphagia, difficulty swallowing, choking sensation as well, and it progresses over months and years as well. Now, why isn't it polymyositis? Okay, now I can see why you would think that if there is muscle weakness, and obviously polymyositis is due to an idiopathic inflammatory myopathy that affects the proximal muscles, both the upper and the lower limbs as well. However, what we see here, this is distal muscle involvement, okay? The finger, the wrist flexors, which is very unusual for polymyositis. And obviously for polymyositis, that is normally a disease of young people, not older patient population here. Now, what about IBM? We've discussed why it should be IBM, and one of the key things is dysphagia. It's present in well over 60% of patients due to the pharyngeal muscle involvement. Now, motor neuron disease. I can imagine why you might say this is motor neuron disease, and obviously ALS, amyotrophic lateral sclerosis, is a part of MND spectrum because of the muscle weakness, because of dysphagia. However, MND causes fasciculations, this spontaneous muscle twitches, and that is why MND is not likely in this particular case. Also, if you have MND signs, you get muscle atrophy, you get hyporeflexia. This patient's got normal reflexes, so this would exclude it. Now, myasthenia gravis is also incorrect because myasthenia gravis is an autoimmune disorder of the neuromuscular junction, and that gives you fluctuating muscle weakness. So people get fatigability. They get worse at the end of the day. They get worse if you overuse the muscle again and again and again. So obviously you could get a bit of dysphagia and proximal muscle weakness. The distal muscle involvement is very atypical for myasthenia gravis. It's normally more proximal. Hypothyroidism could cause a bit of myopathy, okay? That's more proximal. This is all distal, so that's why the pattern of disease, the pattern of weakness is different. Let's go through this question now. We've got a 80-year-old man with a previous history of psoriasis. He's got a 6-week history of pain and stiffness of the left knee and a swollen right index finger. And the pain is worse in the morning and is associated with the early morning stiffness lasting more than 30 minutes, which is improved with use. So when you examine the patient, the synovitis of the left knee is confirmed. Where do you go next? Okay, what do you do next? So this is a 30-year-old man with a previous history of psoriasis that's got a 6-week history of pain and stiffness of the left knee and also the swollen index finger. Pain is worse in the morning. It's got early morning stiffness and gets better with time. So where do you do next in terms of investigation? You go A, ultrasound, B, CCP and rheumatoid factor, C, FBC, a full set of blood tests, D, chest x-ray, or E, specific x-ray of the hands and feet. Have a think. I'll give you 4-5 seconds. Well, let's have a think in terms of the diagnosis first, guys, right? So this patient's got psoriasis. He's got asymmetrical oligoarthritis, so that means he's got asymmetrical left and right side, and he's also got the left knee and the right index finger, so this is asymmetrical completely, and he's got morning stiffness. So this suggests to me that he's probably got psoriatic arthritis, which is a chronic inflammatory joint disease, which is associated with arthritis, okay? And that's often got some of the following features that's important. It's got asymmetry joints, so DIP, spine, sacroiliac, knees, etc. It's got dactylitis, so sausage-like fingers due to inflammation of the entire digit, and also they sometimes have enthesitis, which is the inflammation of the insertion point of the tendons and ligaments. They may also have some nail pitting changes, pitting, onycholitis, hyperkeratosis, etc. And also the fact that the vast majority will have negative rheumatoid factor, negative anti-CCP. So, a couple of things. One, you could do ultrasound. That's useful to detecting things like synovitis, enthesitis, dactylitis in psoriatic arthritis, especially when the clinical examination is rather equivocal. However, we already know this patient has got synovitis of the left knee. We've got that on examination. And so even though the ultrasound of the feet may give us additional joints that may be involved, is not the next important investigation, because the diagnosis can be made just on the clinical presentation and the history of psoriasis alone. CCP rheumatoid factor is not correct because it's not likely to be rheumatoid arthritis, given the fact that this is asymmetrical oligoarticular arthritis, whereas rheumatoid arthritis involves the small joints of the hand and is much more symmetrical, as we discussed. What about C? FBC, renal liver biochemistry. That is correct. Okay, it's very essential because we're going to need to treat psoriatic arthritis. We're going to treat it aggressively with DMARDs, methotrexate, leflunomide. And so this is about long-term management of psoriatic arthritis, and that can cause bone marrow suppression, hepatotoxicity. So checking the full lot of baseline is important before we can monitor this medication. Now, sometimes people do chest x-ray before starting certain DMARDs, especially methotrexate, to rule out pre-existing lung conditions, TB, etc., or serves as a baseline if we're trying to monitor pulmonary toxicity, but certainly not needed for psoriatic arthritis. X-ray of the hands and feet, that may help us assess the extent of any joint involvement or damage, such as DIP joint erosions, anything like that. However, it's not the most important because it's not going to guide the initial management, and the initial management guidance is going to be aggressive DMARD, and to do aggressive DMARD, we need to know the baseline before we can commence it. This is just a generic photo for you guys to have a remember what psoriatic plaques look like. Look at the silver scales. Look at the pink base that's clearly delineated. This is psoriasis, okay? So you may get a picture of this. You may get a description of this rash instead of giving the actual diagnosis. These are all possibilities in the real exam. Okay, guys, this is the last question. Well done. So let's crack on with this. We've got a 68-year-old woman that's got a 6-month history of progressive diffuse bone pain, muscle weakness. She's got problems, difficulty to rise up from a seated position, and she's got previous low trauma fractures in the last year. She's got low calcium, low phosphate, and increased ALP. What is the diagnosis, guys? She's got low calcium, low phosphate, increased ALP. She's got previous low trauma fractures. She's got diffuse bone pain, muscle weakness. Is it A, osteoporosis, B, Paget's disease, C, multiple myeloma, D, osteomalacia, or E, fibromyalgia? What is the correct answer? Have a think, guys. Okay, so let's focus on this particular question now. So if you've chosen osteomalacia, then that is the correct answer. So why isn't it osteoporosis? Well, osteoporosis really is due to a reduction in bone mass and thus increase the risk of fractures in older adults. And this, in the vignette, it may be associated with diffuse bone pain and low trauma fractures, but actually it doesn't result in decreased it doesn't result in any muscle weakness, and also it doesn't result in any of the biochemical parameters here, because the low phosphate, low calcium, increased ALP involves bone mineralization rather than bone density loss. So that makes another diagnosis more possible. And Paget's disease of the bone, again, is a good possibility, but that's due to localized bone remodeling, so misshapen bone, enlarged bone, owning a specific area. So that means you get localized bone pain and not diffuse bone pain. Certainly, you might get the elevated ALP due to bone osteoblastic activity levels, but the fact that you get diffuse bone pain and also low levels of calcium and phosphate and muscle weakness is not consistent with Paget's. Multiple myeloma. Now that's a possibility because of the widespread skeletal damage. So that causes bone pain and fractures due to osteolytic lesions, and certainly you get increased ALP. But the key component of multiple myeloma is hypercalcemia, increased calcium levels, which we do not see here. osteomalacia is the correct explanation because you do get impaired mineralization of the bone matrix that leads to softened bone, diffuse bone pain, muscle weakness as well, all of which makes you susceptible to fractures. And often that's due to a deficiency of vitamin D. So that reduces calcium and phosphate absorption in the GI tract. And so that results in low calcium, low phosphate, and increased ALP, muscle weakness, and bone pain. And fibromyalgia, yep, so even though you do get widespread pain, fatigue, tenderness, you wouldn't get increased in things like risk factors for fracture. And certainly you would not see significant biochemical abnormalities. Hence why osteomalacia is the correct answer. So guys, we have gone through all these topics that we've listed here today. We have gone pretty much through the main topics that they can ask you in the UKMLA or medical finals exam that you're going to sit. So hopefully this has been a very useful journey throughout the most difficult questions, the most high yield questions, certainly the most useful questions from a trap point of view from the examiners and how they can set it. Hopefully you found today's webinar useful. Let me know in the comments, let me know by email, let me know how you think about this webinar and what other topics you want me to cover. Have a good day, guys.